All right, the digestive material that we had in the stomach is now going to move to the small intestine. What we call that in the stomach, where our food has mixed with our digestive juices, is called chyme. And that chyme at this point is very acidic and it's going to dump into the small intestine. So the small intestine, we tagged it and asked function. The big word you should think for small intestine is absorption. Yes, some absorption can happen in your mouth, some can happen in the stomach, but the big place that absorption takes place is the small intestine. All right, so digestion's being completed there. We're going to absorb lots and lots of nutrients in the small intestine. And it's actually quite long. For being called small intestine, it is the longest part. So it's extending from the stomach all the way to the large intestine. And in a cadaver, it's about 20 feet long. Of course, in our donors, it's all coiled up, so it's a little more difficult to picture 20 feet. But if we took it, stretched it out, cut all of the connective tissue, holding everything together from end to end, it'd be nearly 20 feet. If 20 feet is difficult to picture, think about our tables in the lab. On a quiz day, we put 3 of those tables next to each other. Each one's about 6 foot. There's 6 feet, 6 feet, 6 feet, all 3 tables lined up. Gets you about 18 feet. So if we took the intestine from one end of that table to the other end, there's 3 tables lined up together, we would still have 2 feet hanging off the sides. That's how long those small intestines can stretch. So small intestine, it's not called small based on the length, it's called small based on the diameter. The diameter is going to be much smaller than what we see with the large intestine. And the large intestine will be pretty much about 5 feet-ish, so decent amount shorter than our small intestines. So with the small intestine, it's divided into 3 regions. We have the duodenum, or again, you can pronounce it however you want, duodenum, duodenum, as long as you can spell it on the final, I'm happy. So the duodenum is our very first part. It's the shortest part of the small intestine. And from there, food will then go to the jejunum and then the ileum. So duodenum, again, first portion of small intestine, much shorter than the rest of it, more than the idea of inches long. Where we're going to see it is right off of the stomach, and it wraps around the head of the pancreas, sort of making a C shape. So we're going to look for the C-shaped part of the intestines, again, wrapping around the head of the pancreas. And 3120, we are lined with simple columnar epithelium. So pretty much the rest of the pathway. Our stomach was simple columnar, duodenum simple columnar, ileum, jejunum and ileum, large intestine, we're going to see simple columnar almost all the way to the very end. So again, simple columnar is good for absorption and secretion. So in the small intestine, we're doing a lot of absorption. One thing about the duodenum that's different than the rest of the small intestine is in the wall, there's a special gland called a Brunner's gland that is in your lab notes, but let's go ahead and add it here. Brunner's, B-R-U-N-N-E-R-S, Brunner's gland. It's in the wall of the duodenum. So histologically, this can help us identify it as duodenum compared to the other parts. And its job is to release an alkaline fluid. Remember the stomach contents, the acidity is 1.5 to 3.5 on the pH scale. We just dumped all of that material from the stomach into the small intestine. Once we get to the small intestine, the enzymes and products we're making for digestion, they don't want to work in an acidic environment. So we're going to work on neutralizing the acid at the very first part of the small intestine. So these Brunner's glands, again, they're dumping an alkaline substance to neutralize the acidic chyme. From the duodenum, we then go to the jejunum. This is our middle part of the small intestine. It's pretty long, I'd say maybe 9 feet or so is jejunum. Again, it's going to be the middle part of the small intestine. And then the last part of the small intestine is the ileum. The ileum is going to lead us to the large intestine, and this ileum is different than the ileum we saw last semester. Last semester we saw the ileum bone, part of your hip bone. That was ILIUM. Ileum of the intestines is ILEUM. And the way I remember that tiny little difference between these two words is ileum with an E is the one that when you eat, food's going to pass through this ileum. All right, so ileum with an I is the bone. Ileum with an E is the one food passes through after you eat. All right, so ileum is our last part of the small intestine. It's also about 9-ish feet, give or take a little bit. So we're going to divide it into its regions. So here we have the stomach, we have the pyloric sphincter, and then chyme will be dumped into the duodenum. Again, duodenum is our first part of the small intestine. It's very short, and it makes this C shape, wraps around the head of the pancreas. And it has, again, those Brunner's glands to release the alkaline fluid to neutralize the chyme. So from the duodenum, the material will then move into jejunum, and then we'll end at the ileum, our last part of the small intestine. Exactly where we transition from jejunum to ileum, it's kind of difficult exactly to find. So to make this as nice and simple as possible, we're not going to be super jerks to you. For duodenum, we're going to tag up here close to the stomach. We'll try to make it as clear as we can that it is wrapping around the head of the pancreas. And we'll ask, identify the region, include of what organ. So you'll say duodenum of the small intestine. From the duodenum, we then go to the jejunum. All right, maybe don't add all those extra letters, but jejunum is going to be this middle part. And we'll just pick somewhere in the middle of the intestines to tag. All right, so we're not going to try to make it complicated and tag close down here and hope you figure out what we're going for. Somewhere in the middle, we're going to tag jejunum. And again, ileum is probably a lot of this, but to be as clear as possible, we're going to go all the way to the end of the small intestine and tag somewhere down here for the ileum. All right, so ileum, we're going to tag close to where we see it going to the large intestine. So duodenum will be the very beginning. Tagging anywhere in the middle will be jejunum. Tagging the very end will be ileum. If you'd end up going on to get maybe a degree in anatomy or you want to go to medical school, then there are ways to tell exactly where we have the jejunum versus the ileum. A lot of it's by looking at the blood vessels going to it that we didn't get into this semester. So if you're really, really wanting to know the difference and how to tell jejunum versus ileum more accurately than just tagging in the middle is jejunum, tagging at the end is ileum, come see me and I'll help you so that that's one less thing that you have to worry about when you get to medical school or anatomy or wherever you're going. All right, so again, we have duodenum, jejunum, ileum. You have to know these in order. So I like to remember it as the DJ ileum, bringing you the sounds of the digestive tract. All right, so duodenum, jejunum, ileum. We're going to spend more time on the small intestine. There's a lot going on here. There are a lot of accessory organs that we need to discuss. So again, the small intestine is important for absorption. So what we have are going to be lots and lots of modifications to help us increase the surface area. The more surface area we have, the more we can absorb. So what I just said, we're going to increase surface area, increase absorption. And one way we're doing that, we already said, small intestine is about 20 feet long. That's a lot, coiled all up in your belly. So right there is a decent amount of surface area. In addition to the length of the small intestine, we have modifications inside the small intestine. So it's not a hollow tube like you see with a hose. We actually have a lot of projections poking into the lumen or the inside of our small intestine. And those folds that are poking into the inside are called circular folds. So they project into the space where food passes through. And another name you might see that called in especially older textbooks is plique circularis. Plique circularis. I would tell you just go with circular folds. It's going to be much easier to spell than plique circularis. But again, it's another term you might see out there. But these folds are sticking into the lumen of the small intestine. And off of those folds, we have little finger-like projections that we'd need a microscope to see called villi. So just finger-like projections. And those villi are lined with cells that have microvilli. And microvilli we learned last semester. Microvilli were tiny little finger-like projections off the outside of our cells. Much, much smaller than cilia. They had no role in moving, but they did increase surface area to help us with increasing absorption. All right, so all of these things together increase the surface area inside our small intestine. All right, so here we have part of the small intestine. This specifically is the duodenum of the small intestine wrapping around, here's the head of the pancreas. And inside, if we open up the small intestine, you see all of these little folds. These projections, again, are called circular folds. So it's really not a nice, smooth, hose-like tube on the inside. Off of these circular folds, what we're going to do is zoom in on one of those. So we've zoomed in. This is the top of a circular fold. So imagine you have this big circle, small intestine. This space where my arrow is where food's passing through. Have food on the sides also. So this huge circular fold sticking off up into the lumen. And off of that we have these finger-like projections. Again, these are called villi. And if we zoom in on one villus, so villus is singular, villi plural, we zoom in, we see that there's cells lining the outside. Those cells have microvilli. Again, they increase surface area, increase absorption. All right, so what amazes me is the actual surface area inside your small intestine. It's a crazy number. The surface area of the small intestine lining, you ready for this? 2,700 square foot. 2,700 square foot. That's a huge number. If you look at homes on the market, it gives you square footage of the home. My house isn't 2,700 square foot. The surface area of the small intestine in my body right now has better square footage than my home. That's crazy. Kind of want to go, next time I go buy a house, tell my realtor, all right, so the square footage I'm looking for is somewhere around the square footage of the inside of my small intestine. And see how confused I make her or him. Then you'd have to explain, that's 2,700 square foot. That's a large, at least for me, that's a large house. All right, that's what's inside your small intestine. So what that looks like on our histology slides, and you'll get to see in the lab, something like this. So this is the inside where the food's passing through, so all of this white space to the left of this picture. So what we're looking at is you have to imagine the small intestine is this tube coming out at you, and all we did was took a teeny tiny chunk of the wall. So this is the wall of our small intestine. It goes all the way around, makes a nice big tube. And we just have a little piece and one of these circular folds sticking into where the food's passing through. So this is the circular fold sticking off the wall into the lumen. And then off the circular fold, we have multiple villi, these finger projections poking into the lumen. The way it's cut, you can't see the entire villus some places. It's not the best cut of the tissue, but you can still see we have these finger-like projections. The one in the lab is actually quite nice, so in your notes you'll see that next week or I guess whenever you watch this video. Uh, it'll be on, I think, Tuesday you'll finish this up. If we zoomed in on one of those circular folds to where we just zoom in on the villi, this is one villus sticking into the lumen. So it's white space, food passes through. It's lined with a simple columnar epithelium. So that's a villus, that's a villus. Along the simple columnar epithelium, we have special cells called goblet cells. And you remember what goblet cells make. Been asking you this for 2 semesters now. Goblet cells produce mucus. Alright, so there is a decent amount of mucus being produced along your digestive tract. And then the last thing, which I think is much better to identify in your slide in the notes, is a lacteal. So in these villi, we have capillaries, arterioles, venules. There's a lot of blood supply because we're absorbing lots of nutrients, and we need those nutrients to get into the bloodstream. However, there is one nutrient that is too large to be absorbed directly into the bloodstream, and that's fats. So fats, once it is absorbed by these cells, pass through into a lacteal. And we see blood vessels. Here's a blood vessel. You can see colored pink. There's red blood cells inside. But the lacteal sometimes is difficult to see because it is white inside in our histology slides. Again, the one in the lab notes will be more clear than we see here. All right, associated with the small intestine, we do have accessory digestive organs that we need to discuss. One is the liver. Liver is the second largest organ in the body, but the largest gland. Do you remember what is the largest organ? Fun trivia fact, right? It's asked all the time. Largest organ is the skin. And then next we've had the liver. And the liver is a pretty large organ situated in the upper right quadrant of the abdomen. And we even saw in the urinary lecture that this is a large organ. It's even pushing our right kidney slightly lower than our left. So very large organ. And here we see it sits below the diaphragm. We can see part of the stomach to the left of it. We have the gallbladder down here. And then our intestines are covered in this nice layer of fat called the greater omentum. In lab, what you get to see again, we've dissected things out. We've removed this greater omentum, this flap of fat. A lot of the mesenteries have been cut through to get things mobilized where we can visualize deeper structures. But it's pretty amazing how everything's really actually packed tightly into your abdomen. The liver is taking a decent amount of space. And this greater omentum is actually kind of nice. Even if you're super skinny, you feel like you don't have any fat on your body, this greater omentum is covering a lot of those abdominal organs. If you think about your abdomen, there's not much protection. In your thorax, you have the ribs and sternum helping protect your heart and lungs. But when you get down to the abdomen, there's not much protection. You have these muscle layers in the front. That's about it. So this greater omentum just gives you that extra little bit of cushion under those muscles. Right, so you likely are not going to see this in the lab. We usually dissect that off. With the liver, there are 4 lobes that you're going to identify. So you'll see those in the lab when we do the accessory structures. And 2 of them are easy to see from the front, and then 2 we'll have to flip it over to help you see better. So this picture, what we're looking at is the liver from the front. The right lobe is huge. You can see the gallbladder sticking out right underneath of it, and a lot of our gallbladders are actually green. There's a couple in lab that aren't stained green, but most are. They're filled with bile, a green substance. So it's our huge right lobe. And then next to it we have the left lobe, points over to the left side of your body. And then To see the other two, we have to flip the liver over. So this view, we're looking from under, kind of an inferior posterior view, which makes it a little more confusing. This is not my favorite picture, but what we can see is we do have two more lobes. So by flipping it over, we see that we have a right lobe and a left lobe still, but sandwiched in between the right and left, we have a quadrate lobe and a caudate lobe. Those two, sorry, you have to spell correctly. Caudate and quadrate sound too similar. People like to mix them up and do a quadrate and a quadrate and just confuse it all. So you have to be pretty darn close on the spelling and not make it look like you're mixing the two words together. So the way I remember which one's which, right here we have the gallbladder, and next to it we have the quadrate lobe. There's a magazine out there called GQ magazine, Gentleman's Quarterly. So we have the GQ magazine. So here with the liver we have the GQ. The gallbladder sits next to the quadrate lobe. Alright, so that's more on the bottom. See the gallbladder's down here. The quadrate would be right behind this right lobe, right in this area. And then towards the top we have the caudate lobe. In lab we'll try to situate this in a better way than I think what they did with this picture. But again, look for the gallbladder. Gallbladder is next to quadrate lobe, and the inferior vena cava is next to the caudate lobe. The liver is super important. It has lots and lots of functions. Here's just a few. Dr. Tucci, I'm sure, will go on and on about the liver for a while. But the liver, one thing it can do, stores lots and lots of glucose as glycogen. If you ever want to see a histology slide, I have one specially stained to stain the glycogen, so you can see how packed these cells are with the glycogen. If not, that's fine. But it also is filtering blood. It has special cells called hepatocytes making bile. Anytime you see the word hepato, think liver, and cyte, you know, is cell. So hepatocytes literally translate to liver cells. And then again, those are producing bile. Bile is a substance that's going to help with fat digestion in the small intestine. When you're not using the bile, say you haven't had a meal in a while, you actually can store that bile in the gallbladder. Some people are confused and think that bile is actually made in the gallbladder, but that's not true. Again, bile is made in the liver, and then it's stored in the gallbladder until it's time to use. The gallbladder also can concentrate that bile, so it'll pull water out of the bile to make it even stronger for digesting fats. Can you live without your gallbladder? Some of you are probably saying, I sure can. I had mine removed a long time ago. You can live without your gallbladder, because again, it's just storing and concentrating the bile, but your liver is actually one that is making the bile. It's a little waterier, but it still does the job of fat digestion. It's a little more difficult. Some of you might still have a hard time with digesting fat, but you still are making your own bile. But again, gallbladder is nice to have. With the liver and the gallbladder, we have to have tubes, which we're going to call ducts, to get the bile down to the small intestine so it can be dumped in to mix with the chyme so that we can start breaking down the fat. So we're going to have a series of ducts that get the bile down to our duodenum. And we're going to start up at the liver. At the liver, we have a right and a left hepatic duct coming from the liver, merging together, forming the common hepatic duct, which is carrying the bile away from the liver. The common hepatic duct is visible in the lab. We can see that one on our pro sections and possibly even one or two at the donors. So that one is a likely tag that you'll see on the final. Right and left hepatic ducts, they're a little deeper in the liver tissue, more difficult to see. So common hepatic duct, we should be able to see that on our donors. So with this picture, we have the liver up in the right upper quadrant. You can see they stuck a gallbladder here. This is our duodenum, the first part of the small intestine, wrapping around the head of the pancreas, and then there's the rest of the pancreas pointing over to our spleen. And from the liver, we have the right and left hepatic ducts. Those take bile to the common hepatic duct. And in lab, normally I'd like to draw this with you myself, but in the lab, you're going to draw this out with the TAs and get that up on at least one of the whiteboards. Alright, so getting left and right hepatic ducts coming from liver, merge to form common hepatic duct. And then our common hepatic duct is going to join the duct from the gallbladder, and that one is called the cystic duct. So cystic ducts coming from the gallbladder merges with our common hepatic duct, and that forms the common bile duct, which is going to lead us down, pokes through the pancreas, and enters the duodenum eventually. Alright, so again, liver, we have a right and a left hepatic duct. They merge to form our common hepatic. Here's our gallbladder. From the gallbladder, we have a cystic duct. Cystic, common hepatic merge together, form the common bile duct. That pierces through the back of the pancreas. They've dissected the tissue away so you can see it traveling through the head of the pancreas and headed on its way over to the duodenum. In the pancreas, the common bile duct is going to merge with the pancreatic duct. That's obviously going to come from the pancreas. And the two of those, when they merge together, make a little bit thicker tube. And that's called the hepatopancreatic ampulla. So hepato, we got the tube coming from the liver, that's our common bile duct, and then pancreatic duct coming together. So hepatopancreatic ampulla is in the head of the pancreas, and that has another name, and that is ampulla of Vater. It's like water, but with a V, so V-A-T-E-R. So ampulla of Vater, for me that's easier to say and easier to remember. I mean, this hepatopancreatic ampulla, the word makes sense, but it just doesn't flow out as well as ampulla of Vater. Alright, so common bile ducts coming down through the pancreas. In the pancreas, we have the pancreatic duct, which is dissected well on one of our donors. Maybe two of our donors have it, so you should see both of those, the common bile duct and the pancreatic. And we might even have one that's dissected all the way out to where you can see the two merge, and we get the hepatopancreatic ampulla, or again, I like to call it the ampulla of Vater. Alright, so the ampulla of Vater is right here in the head of the pancreas, and from there we're going to dump into the small intestine through this major duodenal papilla, which is next on our list. The hepatopancreatic ampulla drains through the major duodenal papilla. It's a little peg-like structure that pokes into the small intestine, and you should be able to see that on a couple of our donors. Finally had a really brave dissector in the lab. Most people don't want to cut the small or especially the large intestine open to see anything because you know what's passing through there. It's food that's being digested and eventually turning to feces. And no one really likes to cut it open. One semester, I had a super brave student, and he cut open small intestine, large intestine, and found a lot of stuff for us to see. So major duodenal papilla is one of those we can tag on a donor. We can open the duodenum and pin this little peg-like projection sticking out. Again, bile is going to flow through that into the duodenum. So that is right here. Alright, so bile came down through the left and right hepatic ducts, through the common hepatic duct. Bile can come down through the cystic duct, cystic and common hepatic, drain to the common bile duct, which then goes to the ampulla of Vater, out through our major duodenal papilla, into our duodenum. Alright, at that point we can start digesting fats. One thing that I want you to add around the ampulla of Vater, there is a special sphincter muscle. And the name of it, I think, is just adorable. It is called Sphincter of Odie. And isn't Odie the puppy from Garfield? Garfield and Odie? So, Sphincter of Odie. I'm not having you add it because it's a dog's name. I'm having you add it because it's going to be physiologically important when Dr. Tucci's talking about what's going on with the bile and how it's getting into the small intestine. So, the Sphincter of Odie wraps around the ampulla of Vater, and typically it's contracting. It's pinching off the ampulla so that bile and pancreatic juices aren't just dumping into the small intestine. We don't want to just flow freely all the time. You only want to dump bile and pancreatic juices in when you're digesting food. So the sphincter is typically closed until you have a meal and food starts passing into or through this digestive pathway. Then you'll release something that Dr. Tucci will talk about called cholecystokinin, and it'll relax that muscle so bile and pancreatic juices can dump into the small intestine. All right, pancreas real quick is something you've already seen. You found it behind the stomach. It is a gland that has both exocrine and endocrine functions. You've talked about the endocrine functions. You know what that part is. So let me just ask you, the endocrine portion produces what? If you don't remember, this is definitely, likely, probably a final exam question. We've seen it before the midterm. We're now seeing it again after the midterm. It's a very important gland. You have to know what the pancreas does. So hopefully at this point you have thought insulin, glucagon, and go ahead and add some atorvastatin. All right, so that part's a review. That part is very likely to pop back up on your final. I would expect a pancreas tag. We've talked about it. It was on a quiz. Your TA probably tagged it on the midterm. Probably going to be on the final. If I was a betting person, probably bet pancreas is on the final. All right, so it does endocrine function, but it also has an exocrine portion. Exocrine glands are glands that produce a substance and dump them into a duct or a tube. All right, so like sweat glands, those are exocrine glands. The gastric glands, they were dumping their product into those gastric pits that went into the stomach. The pancreas is an exocrine gland. It's going to produce a substance that's going to be dumped into that pancreatic duct. So it's going to produce enzymes, a whole list of enzymes that help with digestion of carbs, fats, and proteins. You'll get that whole list with Dr. R. So we're producing stuff that's going to help us with chemical digestion in the small intestine. And we're also producing bicarb ions. Right, so remember, earlier we talked about the stomach has very acidic contents, 1.5 to 3.5. We're dumping those contents into the small intestine. The small intestine doesn't want an acidic environment, so we're going to neutralize that acid. So these bicarb ions are going to help us neutralize the acid in the duodenum. We had one other. If you remember, in the duodenum we have those special glands in the wall called Brunner's glands. So now we know two ways that we are neutralizing acid in the duodenum. We have the pancreas making bicarb ions, and we have Brunner's glands producing an alkaline substance to neutralize acid. So you're going to get, again, all of those details with Dr. R. Those enzymes and bicarb ions are going to be dumped into the pancreatic duct that, again, is merging with the common bile duct to produce the ampulla of Vater, and then that dumps through the major duodenal papilla into the duodenum. So here we see pancreatic duct. It looks like a white little sort of tube, kind of stringy looking thing that we have dissected out in a couple of our pancreases. So you should be able to see the pancreatic duct, and again, it's going to merge with our common bile duct at the head of the pancreas. Both bile and pancreatic juices and bicarb going to go through the through the ampulla of Vater, through the major duodenal papilla, into the duodenum. Alright, so next video we're going to get into the large intestine and finish our digestive pathway.